Good evening. Thank you for attending tonight's latest in our series of voter education topics that the League of Women Voters of Alabama is bringing a diverse and wide selection of topics that we feel like everyone in Alabama needs to be aware of the issues, to be able to understand what are the problems that exist, and also how you can make a difference in who you elect, as well as who you want to go talk to after you learn about the issues. And so tonight I am going to hand it off to our moderator, and who is going to kick off our forum entitled Alabama's Maternal Mortality Crisis. And she will introduce the panelists, and let's get going. And I'm going to spotlight Margaret Pace, who is a member of the League of Women Voters. She's a part of the League of Women Voters of Alabama advocacy team, which is a team of people made up of members from across the state who are studying proposed legislation, different topics like reproductive health, to understand the issues and make recommendations to the state board so that we can do more effective advocacy. She's also a member of the League of Women Voters of Baldwin County. Take it away.
Hi, good evening, y'all. Thank y'all for attending. I'm excited to learn just along with you. I am an attorney in South Alabama, and I am here tonight and lucky enough to learn about maternal health here in Alabama with three esteemed doctorally certified nurse midwives, and I'm sure they will correct all my designations, and an obstetrician gynecologist who is directing Oasis Women's Health in Birmingham. They all are trying to incorporate midwifery here in Alabama in a more positive note and expand it in order to address our women's health issues in both our rural sections and our more populated areas. So I'm excited to learn from, first of all, Dr. Elizabeth Muñoz. She's a certified nurse midwife, originally from Atmore, but now she's practicing in Illinois. She's the assistant director of the UAB Nurse Midwifery Pathway. And Dr. Sharon Hawley is also at UAB, and she is the director of the UAB School of Nursing Midwifery Pathway. Dr. Candace Knight is the director of the Nurse Family Partnership of Central Alabama, and they are apparently expanding down to my neck of the woods, and I'm very excited to see what they're going to do. And finally, Dr. Heather Skanes is a board-certified OBGYN who is trying to expand the birthing options in Birmingham. She is already doing so, but she is trying to also establish a birthing center that gives people even more options in Birmingham. I'm going to turn this over to Dr. Muñoz, but first I wanted to address that all of us are employed by different people here on this panel, and I just wanted to reiterate that all of us are speaking tonight on and reflecting our own thoughts and experiences, and not those of our employers. So thank you, Dr. Muñoz.
Hi, everyone. Thank you so much for having us here tonight. I am going to get us started with a look at the data on maternal mortality and what we know right now as it stands in the state of Alabama. As Margaret said, I am a doctorally prepared certified nurse midwife. And so that is the lens I'm bringing to this information tonight. And before we begin with the data, I want to offer this, that the information discussed tonight may be really difficult to hear. And it is even more difficult to live these disparities. Remember, these numbers I'm about to give are people, mothers, sisters, daughters, neighbors, friends, family, lives of individuals all cared for by someone. And I'm always surprised that this information is not more widely known but you cannot know it until you do, and now you will. So let's talk a little bit about the data we have about maternal mortality rates in the United States and in Alabama. The US spends more than any other country on healthcare, but what do we have to show for it regarding maternal health? In 2021, the maternal mortality rate was 32.9 deaths per 100,000 live births in the US, which was increased from the 2020 data, which showed an MMR, or maternal mortality rate, of 23.8 deaths. In Alabama, rates of maternal mortality are worse than that national average. In fact, Alabama has one of the highest rates of maternal mortality in the country at 64.63 per 100,000 births when you examine data from 2018 to 2021. And as far as it goes, we are only second to one other state, which is Mississippi. So we are the second worst, we have the second highest maternal mortality rate in the US. The southern states in general have much higher maternal mortality rates than other regions of the United States. And southern states have the largest concentration of the Black population in the nation, leading Black mothers to carry a disproportionate amount of the maternal mortality burden in Alabama. Maternal mortality rates for Black women in the South average 85.8 deaths per 100,000 live births, where white counterparts in the South average a maternal mortality rate of 38.6. This is the Black maternal mortality rate in the South is more than double the rate of their white counterparts, and this is unacceptable. More than half of recorded maternal deaths in the US occur after the day of birth, during the postpartum period, which is now considered to be up to 1 year after birth, and causes of death vary widely, with death from hemorrhage most likely during pregnancy and birth, and deaths from heart conditions and mental health-related conditions such as substance use and death by suicide are the most common in the postpartum period. State maternal mortality rates vary widely across the country. In 2018, we saw a range from 30 down to 15. And where you live and what you look like should not determine your likelihood of death in childbirth. Of course, if the issue of maternal mortality was biologically driven, we would see similar outcomes no matter where people live among groups of individuals. And instead, we see outcomes that are worse in states with long histories of marginalizing mothers and communities of color, especially Black women. So everybody take a breath with all of that. What is to be done about this? Tonight, we will remain solution-oriented, thinking big picture about the players, the problem solvers, and the future. How will we address the rate of maternal mortality in Alabama? And one solution I keep returning to is that Alabama has not yet fully integrated nurse-midwifery into the greater healthcare systems of the state. And I'll start off by explaining what a certified nurse midwife is, because I see nurse midwifery and the integration of the nurse midwife into the greater health system as the biggest opportunity Alabama has in correcting course with the issues of maternal mortality. Certified nurse midwives are advanced practice registered nurses having a Master's of Science in Nursing or a Doctorate of Nursing Practice degree, or you can have both, and are most widely known as normal pregnancy and birth providers. But in addition to pregnancy and childbirth, CNMs provide care for anyone from their first period through menopause and beyond. And we even care for newborns up to the first 28 days of life. CNMs can practice in birthing centers, hospitals, clinics, hold leadership positions in healthcare institutions and educational institutions, for example. We can counsel you on your birth control, and we can examine you for an ear infection. We can perform your annual well woman exam and provide your labor and birth care and perform your newborn exams. I like to say that nurse midwives get to know normal really well, and this helps us spot the abnormal earlier before bigger problems present. We can link you to an OBGYN or MFM services when you need a physician's care, and trust me, we will. Midwives love what they do, and we don't do surgery or extremely high risk. CNMs are known for improving maternal health outcomes with our relationship-based model of care, and we love to partner with our physician colleagues by working in team-based models within health systems. And this This team-based model is where the data shows us the best outcomes exist, especially for vulnerable populations. And finally, CNMs hold a national certification in the United States. We can be licensed in all 50 states. And fun fact about Alabama, did you know that nurse midwives have been employed in Alabama since the 1930s and 40s and were responsible for improvements in maternal mortality even back then? So now that I've given you a look at the numbers and the history of certified nurse midwifery, I'm going to pass the mic to Dr. Hawley to teach us a bit about the history of midwifery in Alabama and how nurse midwives contributed to reducing morbidity and mortality from the beginning. She'll also provide a bird's eye view of how the medical system is set up in the state and why we have some unique challenges in Alabama regarding maternal mortality. So Dr. Hawley, I'll toss it to you.
Thank you very much, Liz. It's a great overview. And I just wanted to say thank you very much for that overview of where we're sort of sitting. As far as midwifery in the state of Alabama, I want to kind of go back a little bit to talk about how midwifery in general is a profession that is as old as humankind. We are not a new profession. We're not just a hippie profession. We have been around for eons. Anytime somebody was having childbirth, there was likely a midwife there. And historically, we were actually revered as professionals that the community wanted, supported. In fact, if you look at our own country's history, some of the first people that were brought to this country, both the Pilgrims as well as enslaved people, some of the very first people that they brought over were midwives. And so obviously our Native Americans had midwives, you know, so the thing is that I want it understood that this is not some crazy profession. We have been around forever. And globally, the World Health Organization has stated that the world globally has a shortage of over 900,000 midwives within the next few years. So not only is Alabama really in need of midwives, but the world globally has a shortage of them. So with that said, I'm going to talk a little bit about Alabama in particular. Alabama used to have midwives in every community. They were well-known people. And then around the time of, you know, it was the turn of the century, around the 1900s or so, the medical profession started to organize. They started to develop their education, their licensure. The nursing profession started to develop its licensure, its education standards. But midwives were always people within the community, and they unfortunately did not develop their own professional licensure and education in the same standards, because they saw themselves mostly as community helpers and there to serve at any time. What happened legislatively in the early 1900s was that there was an attack on midwifery. So we go from about the 1920s, 1930s, we had about 3,000 plus midwives in this state. That's a lot of workforce. We currently have licensed, we have 22 to 23 certified professional midwives, and we currently have 49 certified nurse midwives in this state. So talk about a shrinking workforce. That really was a significant drop. And you may ask, why? Why did that happen? Well, what happened was legislatively, there was some federal legislation in the 1920s, 1930s that put midwifery training under nursing. So rather than recognizing it as its own separate profession and bringing it within the healthcare system as its own thing, like many other European countries did, we decided that it would be under the nursing purview. And therefore, some of the laws also began to challenge midwifery and their profession, and really ultimately in the long run limiting the ability of midwives to work. And so around the 1980 timeframe, we see the last midwife being allowed to have a license in the state of Alabama to practice. Now, the certified nurse midwife came out of the profession of the public health nurse. and had additional training and skills for midwifery. And so then you see sort of this marrying of nursing and midwifery, although it's really two separate professions that have come under the same umbrella. We are currently listed in this state as advanced practice nurses. So we have the same structure of licensure and monitoring that the nurse practitioner does in this state and that the certified registered nurse anesthetist does. And so we fall under that umbrella of nursing, if you will. And at this point, I'm going to kind of turn from that aspect of just our general history to some of the barriers that are in place for us as advanced practice nurses. And so that includes nurse midwives. So I just want to explain, so anybody who's not really familiar with our structure here, various different states have licensure and practice authority. And so our state is one of several states that still requires a collaborative practice agreement with a physician. And in order for us to work and be licensed in the state, we have to have a collaborative practice agreement with the physician. It's a written document, and we have to pay, well, actually the physician technically pays this fee, but many states now have something called full practice authority where they don't have that requirement. Now you may say to yourself, well, wouldn't it be safer if we had this collaborative practice agreement in place? Well, first of all, research actually doesn't show that there's any safety issues with not having that in that collaborative practice agreement in writing. What we do know is that by implementing advanced practice nursing into healthcare systems where we're team-based, we have better outcomes anyway. So in Alabama, it's sort of actually a barrier to access to care because it limits the ability of where an advanced practice nurse can actually practice. We have to be with a physician and wherever the physician is practicing, basically. So I think that will help you understand a little bit about some of the practice issues that we have. I also just wanted to highlight the impact of what's going on in our state with regards to Medicaid expansion. We have not had Medicaid expansion here, and you've probably been reading some of the headlines about hospital closures and the labor and delivery units in particular closing. And I just wanted to share one map with you that I think kind of just says it all. Let's see if I can find my map to share. Let's see, sorry, I'm having a moment here where I can't find what I want. Hang on just a second here. Okay, now I've got it. Well, I say I've got it, hang on. One more time. Okay, here we go. So I don't know if any of you are familiar with the perinatal quality committee that is actually, it oversees a lot of initiatives to help improve maternal and neonatal issues and safety issues. This map, and it may be a little hard to see, but this map highlights where the obstetrical services are with regards to hospitals across this state. Where you can see the green dots, the red dots, and the blue dots. These are all areas that have hospitals with obstetrical services. These have been shrinking over the last few decades, and very much so in the last few years. And so you can see, just looking at this map, if you're in North Alabama, you're probably pretty well off. If you're around the Birmingham area, you're probably pretty well off. Montgomery has a few, Mobile has a few. If you're anywhere else, it is very sparse. Now imagine yourself, your daughter, your sister, whoever that you know who is pregnant, who lives in one of these more rural counties. You are going to have to drive a long way. This is where we are really suffering in this state, for one thing, is the distances between these services, and they're getting fewer and fewer. So I wanted to point that out. And one of the answers might be that we can have birth centers. However, that has had some challenges, and I'm not going to go into that because I think Dr. Skanes probably can speak somewhat to that. And I also just wanted to point out that there's tons of research about when we integrate nurse midwifery into healthcare systems that things improve. And I can show you one more slide, if you don't mind, on one example of many, actually, but this is just one example. When you integrate nurse midwives into health systems, it's just this one slide, really. This is a slide that kind of shows where they integrated more and more nurse midwives into health systems, that the rate of the cesarean section is decreasing overall. This was from an article actually from a physician who isn't all that particularly enamored with nurse midwives, but they even acknowledged that nurse midwives, when you embed them into the system, it makes a difference. Now, you might say to yourself, well, if we decrease C-sections, are we going to have more problems with babies, you know, having issues, or moms having issues? Maybe they should be doing more C-sections. But in fact, the research definitely supports the fact that these things also improve. So reducing C-sections does not necessarily create problems. It actually is just a form of seeing that providing this type of holistic care can impact positive outcomes. And so with that, I am going to, I'm not sure who should go next, actually, but maybe Dr. Skanes, you might want to talk a little bit about what you've been doing. And then I also want to say one more thing, which is community-based care. So one of the things that happened in the 1960s or so, when Medicaid became law, one of the things that happened with Medicaid was that the part of the federal law was that hospitals, that births had to be provided in the hospitals. So immediately overnight, everybody switched to hospitals because that's where you could have your birth paid for. Now, the bad side about this is that everything's now an acute care situation rather than also complementary, you know, community-based care. And so I think that that is something that really the other two speakers that you'll hear tonight can also speak to. So I now will be quiet and turn it over to Dr. Skanes.
Right, thank you. I wanted to talk a little bit about some of the things that you guys mentioned as far as hurdles to bringing nurse midwifery or midwives in general, integrating that into the healthcare system. So I'm glad that you brought up the collaborative agreements, because I think that that is a huge hindrance to bringing access to midwives, because there are so many physicians who are scared to enter into a collaborative agreement. The reason being is because now, as a physician, you also accept all liability for that person. And as you know, obstetrics is a it's a high liability field, right? That's the nature of the United States. People sue for things. So that is an unnecessary barrier, because people are concerned about lawsuits so much in obstetrics. It can actually become a hindrance to care, meaning now I don't want to sign on and get a nurse midwife, even though it probably would improve your outcomes. But not only that, now I'm doing more unnecessary C-sections because I'm concerned about a lawsuit. So those are really big hindrances. And then the collaborative agreements. We also talked about the fact that you don't need a piece of paper to collaborate. And most of the time you don't collaborate via formal contracts. So for example, as an OBGYN, I would consider myself a collaborative physician, period, right? So if I need a cardiologist, I don't need a contract with the cardiologist for them to see my patient. I would just expect them as a professional to see the patient because I'm concerned about XYZ, which is in their specialty, and they usually would see the patient. And the same would happen without collaborative agreements, right? So a nurse midwife or CPM might see a patient and they feel that something is beyond their scope of practice, and then they would refer them to an OBGYN or an MFM, whichever is most appropriate. And because that is now my specialty, then I would see the patient as appropriate. So you don't need a contract in order to do that work. It's actually the nature of medicine, is to collaborate with people. The other thing I think, which you kind of touched on in the end, was a great point that I was going to bring up, which is the issue comes of money, right? So in order to sign this contract, now everybody has to go to the hospital, right? In order for the hospital to get certain things, they have to sign certain contracts. I mean, to get certain things free, they sign certain contracts to give those to the patients, right? So that's what we see with formula and things like that. And then people's insurance not covering them. So now you have to go to a certain hospital because that's all that your insurance covers, or you can't use a midwife because your insurance doesn't cover a midwife. So this is all a very tricky game that at the end of the day does come down to money. And so I think that a lot of times people feel like this is complicated. It's actually not very complicated. Our reimbursement should just be for the service. It shouldn't matter who your provider is, right? If someone is there to assist you with your birth, they get the reimbursement. It shouldn't matter where you have your baby. Your reimbursement should be the same. But unfortunately, that's not what we see in the state of Alabama. When you look at reimbursement, which is one of the things that is also a hindrance for physicians bringing on nurse midwives, the reimbursement for a nurse midwife doing the delivery is 80% of what I would get paid for doing the exact same delivery, right? So financially, it becomes less incentivizing for a physician to take on this agreement, right? But when we're talking about looking at solutions, I and many others in the state feel that birth centers are a very reasonable solution to the access issue that we have. Birth centers are evidence-based. They also incorporate nurse midwives in a way that they can practice in their full scope, which is not necessarily what we're seeing in hospitals right now. And they're also cost effective. So you're going to have more vaginal deliveries, less C-sections, so less cost to the patient, and you have better outcomes, so less postoperative complications and things of that nature. So birth centers could fill in some of those gaps that we see on the map that Dr. Holly showed us, right? We see huge gaps between Birmingham, and I think sometimes it's kind of hard when you're just looking at it on the paper, but you think about that drive in the map that you showed, the drive between Birmingham and Montgomery is what, an hour and a half? There's nothing in between there. That gap from Birmingham to Gadsden, there's nothing in between there. That's an hour drive. So if you're in that gap, that is huge, right? So I will leave it there, and then I'll pass it along to talk about some more solutions.
So I guess that's my turn. And again, I'm Candace Knight. Just a minor correction. I am not a nurse midwife, although I believe Liz has made me an honorary nurse midwife in jest, but I am a big fan of nurse midwives. My role is more as a community health nurse. So, Dr. Holly mentioned that community-based care is really vital to the health of our moms, our families, and one of the things that I do in my role is connect women with home visiting nurses, maternal child health home visiting nurses. And what we found is that when women have an advocate who comes to their community and even into their home, who helps them to connect with all the resources that they need around maternal care, that provides education and all sorts of assessments around those things, that they have better outcomes. Now, we have women in urban settings in Jefferson County and in Montgomery, even in Huntsville. Women have a lot more opportunity to connect to the supportive services that they need, whether it's maternity care or transportation or education or jobs, things like that. When you get into those rural, to connect women and families to the services that they need. If you are living in that rural setting and you need transportation an hour away to the nearest maternity care hub, then sometimes that's really difficult to find. We have great resources in urban settings like Kid One Transport that can move moms and babies and children to the care that they need. But those services get really limited in rural settings. And so, one of the great things about being embedded in these community settings, in particularly these small rural settings, is that we're able to highlight what those needs are for that community and advocate for those. And sometimes it's transportation, often it's housing. Now, I'm sure you're all aware that we live in a very poor state. There's a very high percentage of our state lives in poverty, and in particular, single mothers in our state very often live in poverty with their children. And so, our goal here is to make it easier for these moms to access care, whether that's through nurse midwifery, whether that's through home-based, home visiting of a nurse, or having obstetric care that's just closer to their home in some other way. We really feel like that's the way that we can start to improve the outcomes in this state, whether it's maternal mortality, infant mortality, preterm birth, all of those things that we see in Alabama that unfortunately Alabama is most often at the top of the list for those poor outcomes, or near the top of that list. I would say another solution that has been talked about a lot is telehealth. And we saw in the pandemic that was a very useful way, or a very easy way for a lot of people to get care. And when we're talking about our votes and there's funding available to expand broadband access so that telehealth is more available in the rural communities, because I don't know if I've broken up yet, but I live in one of those rural communities, and my Wi-Fi is not great. So hopefully you can still hear me. But that's one of the things that we see with nurses who are going into these rural communities. Sometimes they're in homes where there's no cell service, there's no cell signal. So if they really wanted to contact a provider and do telehealth within that home setting, they would really be hard pressed to do it. And so as far as solutions are concerned, I think, we really need to think, not only about the specific maternal care, but also the environment in which these families live, and live, work, and play. We call those social determinants of health, and those are really important as we talk about improving maternal and child health in this state. So I'll stop there.
First of all, we really appreciate all of your information that y'all have given, and appreciate everything you are doing to help Alabama. We do have some questions as follow-up, and I hope that's okay. I would like to ask Dr. Skanes if she could elaborate a little bit more about, from a patient's perspective, what would be the difference in birthing in a hospital and birthing in a birthing center?
Okay. So birthing centers are for low-risk people. So meaning you don't have any significant medical problems, like you don't have any blood pressure problems, you don't have any diabetes that requires medication, things like that. When you give birth in the birthing center, that means you're not getting an epidural. This is for natural, normal, physiologic birth. We're not putting you into labor. We're not augmenting your labor with Pitocin or any of those things. You're coping with your labor pains using natural methods to do so. And it's expedited recovery, which means that you're not staying overnight after you have your baby. You're staying for a couple of hours for recovery, and then you and the baby are going home. It's also different in that your total care will be provided, and 95% of birth centers is going to be totally provided by midwives. So there's not going to be an OB there, most likely. There's not going to be a pediatrician there. It's going to be you're going to be completely cared for by a midwife. And then you would be seen somewhere in the next 24 to 48 hours at your home by that midwife to make sure that you and your baby are well. And the biggest difference, I would say, between the birth center model of care, hospital-based care, but midwives in general, is that the focus is on prevention. So it's a lot of education. The visits are longer. They're spending a lot of time prepping you, getting you ready for childbirth, getting you ready for caring for your child, getting you ready for parenthood, and things like that. So I wouldn't say a little bit different. It's a lot different than giving birth in a hospital.
And if there's an emergency, for instance, at a birthing center, then what would occur?
So then the emergency will be managed by that midwife. And if you require transfer to a hospital, then you would be transferred to a hospital where you would see a physician.
Thank you. Dr. Holly, would you mind going into a little bit more detail about how specifically, Dr. Skanes talked about the birthing centers and hospitals and the differences. But as far as the care received by a midwife versus an OBGYN on a regular basis or on the prenatal visits, what would the patient see as a difference, or what are the differences between the two?
Oh, so the training of, I'll just kind of start there. The training of the two are different, but complement one another. So, and Dr. Skanes, feel free to jump in with anything that you want to add to this. But I have been involved with training medical OBGYN residents, actually. So I do feel like I kind of understand the differences in the training. The training of a physician, although they are trained to deliver babies, low risk pregnancies and births, really their specialization is in high risk. I mean, that's really what they're specialists in. And if you want to look at it that way, midwives are specialists in supporting normal physiologic birth and birthing processes. It doesn't mean that we don't take care of patients who have some risk factors. We do. But it's a very nice complement when you have a team of midwives and physicians working together to provide care. The thing is that 80% of patients who are pregnant, honestly, are low-risk patients. The vast majority of patients could be cared for by a nurse midwife, and maybe including, some consultation here and there with the physician. The vast majority of patients, if we were to flip the number of nurse midwives as compared to what we have currently, you would see that there would be increased access to care, and the visits are really much more focused on health promotion, health wellness, rather than sick focus. So what I mean by that is nurse midwives typically are kind of coming into the room going, everything's normal until proven otherwise. And my physician colleagues generally I see as trained as everything's sort of sick until proven otherwise. And that's not bashing anybody. It's just the way that we're both educated. Our professions are educated, because frankly, the physicians should be taking care of the sick or high risk patients, right? We need that specialty. But if you look at countries where they're doing really, really good prenatal care and having great outcomes with maternal outcomes and neonatal outcomes, they have way more midwives taking care of patients than you see physicians. Physicians are really the specialists for taking care of problems. So I kind of answered your question, but I might have gone off a little bit off the rails, but I just kind of wanted to put that out there. So do you have anything else to add, Dr. Skanes?
No, I think that is so true. We're always looking for an emergency, like we're looking for the problem when we come into the room. And I think that is sometimes why patients may feel underserved. Because if you come to your prenatal visit and you don't have any problems, and then, your physician's like, oh, okay, I've measured your belly, I got your heart tones, okay, no problems, okay, bye. Like I see a lot of TikTok videos like that all the time. Like people are like making fun of their prenatal visits. But I think that's why people feel that way, because if someone who's trained to look for a problem doesn't see a problem, they're going to move on. But if you're trained to speak on wellness, you're going to spend a lot more time speaking on wellness, which is what a lot of people need right now. They want you to talk to them about what is normal in pregnancy, what I should be feeling at this many weeks pregnant, like what should I be doing to prepare to breastfeed, what should I be doing to prepare for childbirth. And that's not what we're necessarily seeing as a part of the landscape of prenatal care being received in the state of Alabama.
I also would like to just ask Dr. Knight in on this conversation, because I think also when you marry sort of that nursing component to helping both during the prenatal period and the postpartum period, and having that nursing care involvement like she's an expert at, I'd kind of like her to speak a little bit to that too, and what difference the patients see when that happens, because many patients don't get that experience. Candace, are you able to talk about that?
couldn't, you broke up. I couldn't hear your question.
Oh.
Can you repeat it? Sorry.
Sure. I was asking if you could speak a little bit to when a patient gets the sort of the intercare of having a nurse, especially in the community, caring for the patient both during pregnancy and birth, not just the provider, I guess is what I'm trying to say. When your patients are lucky enough to have that extra care in the community. And so I wanted you to speak on that and what difference that makes for patients.
Yeah, I mean, I think it's really important because, in our current model, a woman has a baby and then she goes home and 6 weeks later she's asked to come back and for one checkup. And what we find is during that 6 week period, there's a lot that happens, and it's really important and really valuable to have that nurse in the community who's there to do those weight checks on baby, who's there to take vital signs and make sure there are no red flags that have come up in that short term. And also help moms communicate what their findings are or what they're feeling to their provider. I mean, we've often have instances where moms have just communicated to their provider, I just don't feel right. When as a nurse, when you go in, you explore a little more, well, what exactly does that mean? And, oh no, this is something that is a major issue and you need to be seen immediately. So sometimes it's that translation of care in the community that can be really really life-saving in a lot of instances. And in others, it can be really comforting to have that reassurance that your baby's growing well and that you're healing well. And those kinds of things, when you look across our globe, we see that done really well in other countries. And it's very low tech, but high touch and really improves outcomes. So thank you, Sharon, for asking that.
And I would even say, Candace, I've had patients who've participated in this program with the nurse. And I didn't know what it was at first, but even as someone who I do an early visit, like an early telemedicine 2 weeks postpartum, I still find it was really helpful because then they could say, the nurse came by and she mentioned, I wasn't going to say anything, but she mentioned that I should say something to you about X, Y, or Z. And so I feel like that it's really, really helpful for patients to affirm whatever their concern is, like you mentioned, or explore it a little bit further, even when they have a sooner postpartum visit.
Yeah, I'm glad she told you. That's awesome.
Margaret, I want to just take a moment, if I can, to highlight something that I just saw in the chat, which is from Karen Barwick. She says, I consider myself well-read and educated, but had a very different impression about midwives and their level of education. Perhaps messaging about this could help. And Karen, you're absolutely right. I like to say that midwifery has a PR problem. We aren't in the US specifically as well known, but when you look around the globe, as Dr. Hawley mentioned earlier, it is midwives who are providing the majority of normal prenatal, birth, postpartum, newborn care. And so I have a colleague and friend who likes to say that midwifery should be mainstream. And so I hope that's the direction that we are moving in Alabama, to make midwifery mainstream, because it is a wonderful model of care, relationship-based care that combines the elements of nursing, midwifery, and then when we partner with our physician colleagues, we bring in the medicine piece, and you get really nice, well-rounded care. So thank you for highlighting our PR problem, and now you know, and you can be a promoter and supporter of nurse midwifery.
And I do want to say that part of the reason why a lot of people don't know about us is because we have sort of purposely been kept out of the state in a lot of ways. So it's not, through your lack of knowledge, it's not, what am I trying to say? It's not because you're not well read or whatever. I mean, we're literally hardly here yet, but we are developing that workforce. This is something that you're going to see expand more in our state. I've worked in other states where we had way more nurse midwives integrated, and people would say, "Oh, I've had a midwife deliver me, whatever." It was much more common that, in that area, people knew exactly what I did. Here in Alabama, I'm still explaining what I do. So I came home to this state in order to grow this workforce. And so I'm hoping that in the next 10 years, I don't have to always explain what it is I do, but just where I do it.
Sharon, could you speak more to that? I mean, I don't think people necessarily know that you guys restarted the nurse midwifery program. I don't know how much you can speak about it, but I think that's important as a part of the solution.
Yeah, so we've just restarted our nurse midwifery program here again at University of Alabama, Birmingham, UAB. And we have 2 classes of students now. And so, we're trying to be part of the solution. There are other things we know that are evidence-based as well that are part of the solution, including use of doulas, including, support of physiologic birth processes rather than always intervening and trying to, do things to people, supporting the normal pregnancy processes and childbirth processes, implementing things that nursing can really do, getting our OBGYN physicians, and also I should say family practice OB physicians, help in the state, support with payment, so reimbursement to hospitals that it helps them stay open. These are all issues. I often think to myself, why is it that we haven't screamed to the high heavens about maternal and newborn care being a top priority? Why are we not considered a critical service that has to be available within certain stretches of space in our state? Like, I don't understand that. Other countries do it, but we somehow think of it as sort of a nice luxury service. And I think that's a mindset that we have to figure out how we're going to solve that. Because if we actually turned our heads to think this is a critical need, what would we do differently? Because currently what we're doing isn't working. So we got to do something different.
Dr. Knight, would you mind expanding a little bit on Dr. Holly's comments about where your organization attempts to bridge the gap in the long stretches of highway between hospitals and what those organizations or the locations look like?
Yeah. So, I saw in the chat somebody asked, is there home visiting in Alabama? And so, yes, there is. Their Nurse Family Partnership is the organization that I'm in. Nurse visiting, home visiting program, but there are several others. There are the Parents as Teachers, there's From Day One, there's Head Start, there is Healthy Start, there are a variety of others that utilize community health workers. And so all of those home visiting programs have the capacity to see pregnant and parenting mothers, and but they all have a little bit of different windows of opportunity. Some, are pregnancy and postpartum, and some are pregnancy all the way to baby turns 5 and those kinds of things. But it's another set of eyes and ears in the home to check for warning signs, things that could be going wrong within the pregnancy, with baby as they are growing and developing, or making sure that milestones are being met, and things, making sure those families are getting access to care. Sometimes it's mental health care that folks need access to, and so home visiting services can make those connections. And it definitely doesn't take the place of prenatal care or postpartum care with a provider. And connect to resources. And so those are some really important things. We are, our nurse home visitors could even be able to go into the homes and do prenatal care through telehealth with that provider. So that's something that we're looking at, maybe using to fill some of those gaps in those long stretches of rural roads and can't access care.
Dr. Munoz, could you fill in some of the gaps of we danced around some obstacles to setting up the midwife partnerships. Could you directly just tell us a little bit more about those obstacles?
You mean between the midwife and a physician collaborator?
Or a midwife practicing by themselves?
Sure, yes. And so I can talk about that broadly, but Dr. Skanes highlighted a big piece of it, which is the reimbursement rate that we see differing between nurse midwives and physician colleagues for the same services. And so when we look to states that surround Alabama, you will see higher reimbursement rates in the states surrounding us. And so therefore the workforce of nurse midwives might prefer to work in those states where they will be paid a more appropriate living wage. And you can't blame them for that, right? If I go 2 miles this way and I can get reimbursed at 95% or 90%, why would I work somewhere where I'm only going to be reimbursed at 80% for the services I'm providing? So really, it's a loss for the state of Alabama because we're losing. There are midwives. We see a false rise in the number of nurse midwives when you look on the Board of Nursing's website, because now we have multi-state midwifery licenses. So we have people who are licensed in, say, Mississippi and Alabama, but they only practice in Mississippi because that's where their income is more generous and more appropriate for the same services. So again, we can't fault someone for seeking out a more lucrative or more fair livelihood, right? But so that's a barrier. I think the historical piece that Dr. Hawley shared and that I gave a little bit of history from, where nurse midwifery has a bumpy history in the state of Alabama and midwifery in general. And so as we look to the future, really building the way to integrate the midwife into the health system as a supported member of a healthcare team. And by doing that, we legitimize the profession of midwifery, and we get, at least within the state of Alabama, and we get the word out there. So I think it's on some portion lack of knowledge, on some portion it is, nurse midwives working elsewhere because of reimbursement rates. The historical bumpy road that we've come down. And then we have some other barriers that exist just with the hospitals closing, with the lack of places to birth. As more and more spaces shut down, that's one less place we can have a nurse midwife, right? And we will see that with our physician colleagues as well. One less place that physician can live and make their living. So why would I live in where I'm from, Atmore, Alabama? Why would I live there when I can live in Mobile and I don't have to drive an hour to my hospital? Mm-hmm. So we have to get these spaces, get their labor and delivery units back up and running.
One other thing I was going to mention about the closures is I think it's important to note that good outcomes are not reimbursed, or not acknowledged by our healthcare system. So even though you may have a hospital like we did have, which has had the lowest C-section rate in the city, has the best outcomes, volume is what's valued in our system, because your higher volume means higher reimbursement, which means, in capitalism means everything, right? So I think it's really, really important to realize that that's the way the system is, because maybe, we need to vote for people who are going to look at the actual outcomes, like not just that 5,000 people had a baby here, but like what happened to those 5,000 people when they had their baby there? Did 1 in 2 of them walk out with a C-section, which is something that we see here in the city of Birmingham. There's hospitals that have C-section rates that are 41%, and no one's looking at that and investigating that further, right? They're just saying they're doing lots of good work over there. They're really busy, you know, they're getting them in, they're getting them out. And so that's really a critical flaw in the way our healthcare system operates. And I think also Dr. Holly mentioned a really good point, which is that some hospitals are critical access points and should be seen as such and should be treated as such, meaning we're going to keep this labor and delivery open. It doesn't matter if you have 10 deliveries or if you have 100 deliveries, because it's a critical access point, because there's nowhere else in between here. And I don't think that that has been considered.
This is not any official response, but I have heard that a certain legislature said that the critical assets point will be solved by our highway system. But
Lord.
it's neither here nor there. Would you be able to talk a little bit more about the C-section rate in Alabama? There's a question that asks, is Alabama actually doing more C-sections than the national average?
Yes. I think our C-section rate is 35%. I think the national average might be 30 or 31%, which is still high. The national average is still very high.
And
one thing I want to add about C-sections, not about the rate, but just about C-sections. The hard thing about C-sections is if you are the patient or the patient's family and your physician says to you, you need a C-section, are you ever going to question that? Nope. You're not going to question that. And the people who are making those decisions about doing the C-section always think they're doing the right thing. And you know what? If you get a good, healthy baby, then you did the right thing, right? So it's sort of self-fulfilling. But the problem is that if you look at how care is provided, for example, the interventions that are put in place to for women who don't necessarily have risk factors. What do I mean by that? For example, early induction of labor when you don't have a risk factor to be induced for labor. That sets a pathway that you may go down and end up with lots more interventions that you didn't necessarily ever need in the beginning. So one of the problems with C-sections is we look at these rates and we go, yeah, but you know what? These people all needed it, right? Or they wouldn't have had it. But we don't also understand that if we prevent that first C-section that was unnecessary, okay, I'm going to caveat that with the unnecessary ones, down the line, you have a whole bunch of long-term health issues that you may not even go down that path with if you prevent that first C-section. Once you start having C-sections, then you're at risk for a lot of different things, different health problems down the road. So when you start looking at cost effectiveness, by preventing a certain number of C-sections, you can actually prevent long-term health outcomes for women. You can actually save costs, save money in the long run, but it's not looked at that way. And so what Dr. Skanes is talking about is we incentivize our maternal health care in a way that doesn't really incentivize good, healthy, quality outcomes. Now, am I suggesting that we should never do a C-section? No way, no how. Like, there are absolutely emergency C-sections that need to be done. But I can guarantee you there are also a lot of them that are done because we should have never started that first sort of intervention in the first place. I've been in this long enough to have seen plenty of those. And the problem is we also don't in our country, we don't stop and look to go, well, what was the first thing we could have, in all of these C-sections? Let's go back to the beginning. What did we do at the beginning of this whole string of events that maybe could have prevented this whole string of events? And that is something that I think midwives are actually really good at. And I think that we could look at doing better in that regard and improve outcomes in a lot of different ways.
I want to jump in there. We had a comment about once someone has a C-section, can they have a normal birth going forward, or they can't have a normal birth going forward? And Judy, that's actually not correct. So once you have a C-section, there are certain things that we like to see as clinicians, like the spacing and timing of the next pregnancy being one of those things. But if the space between pregnancy to pregnancy is greater than 18 months and the scar is on the lower section of the uterus, and there are, if you have a spontaneous labor with that second pregnancy, you actually can have a very high chance of success with what's called a VBAC, which is a vaginal birth after cesarean. And VBACs are supported not only by the American College of Nurse Midwives, but also the American College of Obstetricians and Gynecologists, because with C-sections, as Dr. Hawley mentioned, with every one that you have, your morbidity and mortality for that person goes up. And so I wanted to just point out, when you're looking at C-section data, you're going to see two numbers. One is the overall C-section rate. The other is what's called the NTSV rate. And this is C-section that occurred in first-time, oh, there goes my light, first-time pregnant people. Help me out, Dr. Hawley.
Baby's head down,
thank
so
you.
vertex.
Vertex.
And singleton, one baby.
Singleton pregnancy, thank you. So if it is the first pregnancy, one baby, head down, that C-section rate for that population is actually recommended to be less than 20, I think it's 23% nationwide would be the recommendation. And there are very few places that meet that criteria. So even working on preventing those C-sections for just that population is a big place to start in healthcare or institutions and hospitals.
And a lot of the birthing deserts that Dr. Hawley showed us, with hours in between, is there any possibility of expanding the ability for nurse midwives to give birth? Is to a non-medical person, it seems like an ideal place for a birthing center. Is that even possible here in Alabama?
Well, I think that this is where we are going to have to talk a little bit about the political situation with birth in Alabama. And so I'm going to be very careful about how I approach this conversation. What you have to understand is how our public health system is set up. So it is important to understand that the State Department of Health is intertwined with the Medical Association of Alabama, and that those decisions are all sort of tied together, okay? And so the Alabama Department of Public Health is who oversees, the development of protocols and policies that would be around birth centers. And currently there is a lawsuit that just went through the courts. And so some people may have seen this in the media with regard to how the ADPH has put forth their recommendations for how these birth centers are integrated into the state. And the birth center is a piece of a solution, but unfortunately the birth centers, the way that they're sort of structured to be regulated right now, it actually disincentivizes opening up birth centers that are not necessarily part of a hospital right next door. So I think I'm going to leave it at that, but I think that it is important to understand that birth centers are part of the solution, but the way we have it now in our state, it's going to be difficult to open one.
Understood. There's a question regarding diagnoses that is specifically, we're talking about maternal mortality, we're talking about maternal health, but do you have an opinion on the diagnoses that is most prevalent amongst mothers that do expire, that are part of that statistic? What happens, in other words?
Why are people passing? I think the most common cause is hypertensive disorder right now. It used to be hemorrhage, but We've gotten really good at treating postpartum hemorrhages. We have lots of medications available, but now it tends to be a hypertensive crisis, meaning like preeclampsia or eclampsia, postpartum hypertension that has just been delayed in diagnosis or not properly treated.
And then when you look to the long term, because we know about 50% of maternal deaths in the U.S. Occur the day of delivery, but the other 50% occur in the year that follows. And so one big piece of care is mental health care, preventing and getting people to appropriate treatment for things like substance use disorder, perinatal mood disorders. There are lots of things happening in the body that, for a long time, we just called it postpartum, right? It wasn't even postpartum depression. Now we say perinatal mood disorders, but there are things happening that we can't see, and they're hormonally driven in those first weeks after birth. And what we know, as Dr. Knight spoke on the social and structural determinants of health, when you are fighting policies in society and in institutions that do not promote your best life, and you're dealing with substance use issues, mental health concerns, that's where we're going to see those disparities in vulnerable populations rise, because it's stress from inside the body, from outside the body, all coming to play. So hypertensive crisis for sure, a big issue postpartum, not just day of birth, but long term, but substance use issues and mental health. And that's why having clinicians who are aware of those risks to keep eyes on those clients as they sort of get further away from their pregnancies, and why it was so important to have the expansion of postpartum care services reimbursed through the first year. And that is something that Alabama, Governor Ivey signed in Alabama within this last little bit. So we're seeing the policies begin to acknowledge the risk factors that are out there.
I'm so glad you brought that up too, Liz, because I think that other thing that people, we're talking about maternal deserts and things like that, but it is very hard to get mental health care here, even in a city like Birmingham, which is a major city. Those wait lists to see a psychiatrist is like 6 months long. Like it can be very long. So when you have somebody, we as providers can treat some mental health disorders, but when you have someone who really needs like extensive care, it can be quite a challenge to get people into care. And then there's some people who don't want to treat people who are pregnant. So that can be a struggle for patients. Can you imagine, if you finally get the nerve to call, like, I'm going to do this, I'm going to call, and they're like, we don't have an appointment until 2024,
Yeah.
That may
And
set you back a bit.
yeah, and we do have the birth of the national hotline that is out there for linking people to emergency services. And I don't have it available to post in the chat, but there is a national maternal mental health hotline that is out there that can be accessed with counseling, immediate counseling resources for those in crisis. There is a question in the chat about, can we say anything about midwifery care for incarcerated mothers? And I'm so glad that was brought up, because that is a big issue that we're seeing growing. I kind of keep a tally on the newspaper articles that come out about incarcerated individuals in Alabama who are pregnant. And I know that we have a doula program in Alabama that assists pregnant individuals who are incarcerated. But I don't know of any linking to midwifery services in Alabama for this population, but other states do have this. And that is a space where nurse midwifery could really be utilized. That's not happening yet. And I say yet because there are people all across the state with amazing projects that are in the works. And so, I think that's a fabulous idea on a personal level.
I'm going to tag on to that. I actually, in a different state, I oversaw a practice division that one of the clinics that we provided was care for incarcerated women in the local area. And it was amazing the difference that you could see by having the midwife in that jail every week, a couple times a week, actually. We were able to treat STDs easily, and early. We were able to provide birth control so that they didn't come out and immediately have an unintended pregnancy once they got out. These kinds of things where we were actually immediately impacting these women's lives. The one thing I also want to add is Alabama is still a state where incarcerated women sometimes come in for prenatal care and they're in shackles. And this is something that really is a human rights issue. And that is something that the League of Women Voters may want to consider also advocating to have those shackles removed when somebody's having prenatal care or childbirth. Because you can imagine how, one, it's humiliating, but a pregnant woman, like, where are they going to run to? They're it's hard to run enough, and this is dehumanizing.
Thank you for bringing that up. Is there a way to talk a little bit about what a patient would see that does live in one of these maternal deserts, that if she can't find a prenatal care, or if she can't regularly get to prenatal care, what would her outcome be, and how would it look?
Yeah, I'm happy to comment a little bit on what we see happen when there is less access to care, when there's decreased access, or if we flip it and we say when there are increased barriers to care, we see problems that would not have been as big grow to be life-threatening. We see a headache that started 3 weeks ago turn into a stroke. We see a trickle of fluid. Someone thinks that they're having some incontinence. Actually, that's their water broken. Okay. And so when we don't have the pathway for people to access care quickly and reliably, then we're going to see, we're going to see what we're seeing. The outcomes be the second worst in the nation for maternal health. And so I would just like to say that this represents an opportunity for Alabama to intervene and remove some of those barriers to care by implementing some of the solutions that we've talked about tonight. But the bottom line is, when you don't have the care close to the patient within a reasonable amount, right? A maternity care desert is when you have to travel more than 30 miles to reach your provider. So within a reasonable trip, we can get a Starbucks within 30 miles, not to promote any one company, but we can get a good coffee within 30 miles. We should be able to get prenatal care. And so by removing barriers, increasing access with the solutions we've talked about tonight, that is a way to prevent those bad outcomes. We intervene sooner. We can prevent rather than reflect on the outcome after it's happened.
The other thing I want to add on top of that is that not every hospital has to be a level 3 nursery and a NICU available. Like, what we need are a lot of hospitals that have what's called a level 1, normal, low risk. We need a lot of those. And then we need a few of the top tier academic institutions with NICUs and all of that stuff, just because there are different levels of care that are needed in various different areas across the state. But what we have is a slimmer and slimmer set of hospitals that are available to people. And we don't all need the top hospital to deliver at. Some of us just need that smaller community-based hospital that just is going to serve the community and get you to the bigger hospital if you have a problem.
Well, I really appreciate all of you and all of your thoughts and sharing your experiences. But the League of Women Voters is very action driven. We like to, once we hear about a problem, we want to see if there's anything we can do. Do y'all have, I'd love to go through one by one and see what you think we could do just as voters in Alabama or just members of the community here.
So I wrote down just a couple of things, points, like if you want to write your representatives. So some things that you could mention are: one, we need critical access points for maternity care. We also need fair reimbursement for nurse midwives to be compensated with the standard for their service. We also need outcome-based incentives for hospitals so that we see an improvement in maternal care. And then, of course, we need to remove barriers to having midwives in birth centers in our state. So anything that's going to be overly burdensome to prevent those things from being in the state needs to be removed, because we already know that these things improve outcomes.
Thank you.
I'll add that if there's any work toward legislation for full practice authority for advanced practice nurses that comes down the pike in a few, within a few years, I would ask the league to support that. That's a personal request.
Dr. Muñoz, I know you have already mentioned the expansion of Medicaid. Would you like to add anything else or expand
Well,
on?
I was going to say this is just a person with a uterus to other people who have a uterus or had one in the past, that you ask your primary care person, your OBGYN, that you ask where's their nurse midwife? We need the word nurse midwife said. And when they say, what's that you now have some knowledge to talk about it in a way that isn't, as a nurse midwife, I'm very careful not to say we do anything better than, right? It's not about my care is better than somebody else's. It's about I deserve to be on the team to be able to give the care that I am trained to give. And so that's my ask, just person to person, to get the word nurse midwife out into Alabama, even more than we have right now. Because even tonight, we've said it so many times, and it makes me very happy.
I would add that, I think it's just really important that we are all keeping the needs of families in front of our legislators. Access to care, access to transportation, access to safe housing, safe and affordable housing. All of those things that make our state a healthier place. And so, we've spent a long time in Alabama at the bottom end of these lists, and I think it's really important that our legislators hear from us that our families are important, and we value them having appropriate access to all sorts of services and care, and so just keeping that in front of them.
And I would say one more thing, which is a reminder to all of you that this is a bipartisan issue. This is not a party line. This is a real life. Real people are being affected by this. This is not one side or the other. This affects everybody across the aisle. So don't fall into that trap. This is for everyone.
Please.
Thank you all. Thank you, Dr. Holly, Dr. Skanes, Dr. Knight, and Dr. Muñoz for sharing the real issues here and the real possibilities that we have. And thank you, Kathy, for hosting all of us.
I wanted to thank you all for being here tonight. This has been a real education for me and all of us about the issues and also the opportunities for Alabama to actually have improved maternal health and try to avert the really bad things that are happening across the state with maternal health. I wanted just to also mention to everybody on the call that the the League of Women Voters, during our most recent convention, declared a state of emergency for reproductive health. And one of the positions that's in our impact on position statements is that the League supports the rights of women and those who can become pregnant to self-determination related to and including, but not limited to, bodily autonomy, privacy, reproductive health, and lifestyle choice. And so we really, tonight's conversation is just part of that as we seek solutions. And like you mentioned, there's a lot of legislative opportunities here, and we need to be talking to our legislators. We'll be in touch as soon, we're going to be looking for bills that are coming through the system, but it may be an opportunity for us to find a legislator that's friendly and get one introduced. So these are things that we're trying to push, and so we'll be looking for that. And with that being said, I wanted to mention to everybody that next year is an election year. And so it's not just the president. There's a lot of down ballot elections, including our new congressional representatives. All the 7 congressional districts are on the ballot. There's several judges. So make sure your voter registration is up to date. And then also, we're going to be looking at the legislative session starting in February. And so this is, even before then, you need to be talking to your legislators about the issues that you care about and write letters. And then also go check out the Alabama channel, which is a service that our education fund is providing to whenever there is a meeting. We're recording the live stream, and starting next year, we're going to actually go into the meeting rooms where they're not live streaming and record it, so that people, when you get home from work, you can go look at it and listen to what they said, because we want to hold people accountable in Montgomery. And so thank you so much, and look forward to maybe continuing the discussion again when maybe in the springtime we'll have something better to talk about as far as something good that has happened. So we'll all be looking for opportunities. And I want to thank everybody for coming tonight. And we'll have some more educational forums in the new year.